Welcome to the Hospital Medicine Unplugged podcast. We take deep dives into high acuity conditions, really focusing on the evidence-based protocols relevant for hospitalized patients.
And today, we're tackling acute compartment syndrome, or ACS. It's rare, thankfully, but it's incredibly critical. A diagnosis that absolutely demands immediate recognition, immediate intervention.
Yeah, it's a true surgical emergency. Time really is limb and sometimes even life.
Absolutely.
So our mission today, for you listening, whether you're a hospitalist in critical care, maybe trauma, is to really distill the latest evidence. We're looking at guidelines from the ACS, AAOS, focusing hard on diagnosis, objective monitoring, and of course the management, especially that incredibly narrow window for intervention. Get it wrong, and the outcomes are poor.
Right. And maybe we should start just by defining it, setting the stage for that urgency. So compartment syndrome, it's basically increased pressure inside a closed space. Think of those osteofascial or myofascial compartments.
Like in the lower leg or forearm.
Exactly. And that pressure gets so high, it just crushes the capillaries, compromises circulation, tissue function. It leads very quickly to cellular anoxia and ischemia.
And the clock, as you said, it's just unforgiving. We're talking irreversible tissue damage potentially setting in within 6 hours, maybe even less sometimes.
6 hours. That number really drives everything, doesn't it? It forces that rapid triage, that quick diagnostic process we need to have.
Okay, so let's start identifying who's most at risk. Who walks in the door that should immediately raise your suspicion?
Well, epidemiologically, it's not super common overall. The estimates are around 3.1 per 100,000 annually.
Okay.
But there's a huge skew towards men. It's something like 7.3 per 100,000 in men versus only 0.7 in women. Big difference.
Wow, yeah. Any idea why? Muscle mass, activity levels?
Probably a combination of factors, yeah. Muscle mass, maybe types of trauma are more common, and clinically we see it most often where the fascia is tightest. So the anterior compartment of the lower leg, that's classic, and the volar forearm. Those are the hot spots.
Makes sense. And the causes? Trauma is the big one, right? But not just any trauma.
No, definitely not. Usually it's high energy mechanisms we're talking about. Severe crush injuries are a major cause, extensive soft tissue contusions, penetrating trauma.
And fractures, particularly specific types.
Yes, especially high energy extremity fractures. The tibial diaphysis fracture is notorious for this. You know, the tibia just doesn't have much soft tissue padding there, and the fascia around those anterior and lateral compartments is really tight.
Right.
And we also have to think about vascular injuries, specifically reperfusion injury. You fix an artery that's been occluded, restore blood flow.
And all that fluid rushes back into ischemic tissue, causing massive swelling.
Exactly. That sudden edema is a potent trigger for raising compartment pressure. It's a double-edged sword sometimes, fixing the vessel.
So the danger doesn't end once the artery is repaired. That's a key point. But okay, moving beyond trauma, what about things that happen in the hospital? Iatrogenic causes.
Oh, absolutely. We have to be vigilant for those. Things like IV fluids extravasating, or worse, intra-arterial infusions going interstitial.
Yeah, I've seen that. Nasty.
And prolonged limb compression. You know, a patient positioned awkwardly for a very long surgery, or someone immobilized for hours in the recovery room.
That makes sense.
But maybe the sneakiest, the most dangerous iatrogenic cause, regional anesthesia, nerve blocks.
Oh, yeah, because you take away the patient's main warning sign.
Precisely. Escalating pain is our most sensitive early indicator. You block that pain signal in a limb that's already at high risk, well, you've just blinded yourself clinically.
So if you do use a block in a high-risk situation, what's the implication?
You must shift to objective monitoring. You have to measure the compartment pressures directly because your clinical exam, your reliance on pain is basically gone.
Right, okay. What about non-traumatic causes? These must be tougher to spot sometimes. The mechanism isn't always obvious.
They can be real diagnostic challenges. Often in complex patients, too. We see spontaneous hemorrhage, especially in patients on anticoagulants or those with bleeding disorders. That's a big one.
Anticoagulation is everywhere now.
It is. And then there's severe muscle damage from other causes, like rhabdomyolysis.
Yeah.
Maybe from drug use or prolonged compression, you know, the classic found down patient who's been immobile for a long time. Even severe infections like cellulitis or fasciitis and significant burns, they can all increase the tissue volume enough in that closed space to trigger ACS.
So it's a pretty broad differential, actually. Trauma is common, but you can't rule it out in these other settings. Are there specific patient factors that make someone higher risk, things the admitting team should flag?
Yeah, definitely. Younger patients, maybe counterintuitively, can be at higher risk. Their fascia might be less compliant, tighter. And then, unfortunately, lifestyle factors play a big role. Substance abuse, alcoholism, underlying liver disease like cirrhosis, smoking too. These are all associated with increased risk.
And probably also with altered mental status, making it harder for them to report symptoms early.
Exactly. That's a huge confounder. They can't tell you about the escalating pain, so the diagnosis gets missed or delayed. That's where things get really dangerous.
Okay, let's get into the mechanism, the pathophysiology. Why is this pressure increase so bad so fast? What's happening at the tissue level?
It really boils down to basic physics almost. You've got rising pressure inside the compartment, the ICP, intracompartmental pressure. This comes from bleeding or edema or that reperfusion swelling we talked about.
Right.
Eventually, that ICP climbs higher than the pressure inside the capillaries, capillary perfusion pressure, or CPP.
And once ICP is greater than CPP?
Blood flow stops. The pressure gradient needed to push blood through the microvasculature is gone. Tissues are starved of oxygen. That's ischemia.
And it's not just a one-time event, right? It snowballs.
It absolutely snowballs. It's a vicious cycle. The ischemia itself damages the cells and makes the blood vessel walls leaky, increases vascular permeability.
So more fluid leaks out.
Right. More plasma leaks into the interstitial space, causing more edema. More edema means even higher pressure, which worsens the perfusion, which causes more ischemia.
And around it goes, a positive feedback loop from hell.
Exactly. The pressure just keeps ratcheting up, amplifying itself. The only way to break that cycle is surgical decompression, opening the compartment.
And different tissues handle this ischemia differently, don't they? Nerves seem particularly vulnerable early on.
They really are. Nerves are like the canaries in the coal mine here. They show distress early, usually as paresthesias, that tingling, numbness, altered sensation. That's a key early clinical sign.
So nerve symptoms are an early warning. But what about the muscle itself?
Well, even though the nerve symptoms might be what the patient reports first, the muscle tissue starts showing microscopic damage even sooner. If that pressure stays high, you can see visible changes in muscle within just, say, 2 to 4 hours.
2 to 4 hours for damage to start. But that 6-hour mark seems pretty consistent in the literature for irreversible damage.
That's the consensus, yes. 6 hours seems to be the critical threshold where damage to both muscle and nerve tissue becomes permanent. You really can't get function back after that point.
And if you miss that window, if diagnosis is delayed beyond 6 hours, it's not just about the limb anymore, is it?
No, then you're dealing with systemic consequences. All that dead muscle necrosis releases its contents into the bloodstream, lots of myoglobin.
Right, leading to rhabdomyolysis.
Exactly. And when all that myoglobin hits the kidneys, it can clog up the tubules, causing acute tubular necrosis, leading straight to acute kidney injury. So now you're fighting kidney failure on top of trying to save a limb, potentially dealing with multi-organ failure.
It really underscores the urgency. Okay, so given this tight time frame, clinical diagnosis has to be paramount. We can't wait around for labs or imaging.
Absolutely not. Rapid clinical assessment is the cornerstone. You have to act on suspicion.
So what are the absolute must-know signs? The things we need to drill into every resident, every nurse, everyone managing these patients, beyond just it hurts.
The single most reliable early symptom pain out of proportion to the injury.
Explain that more. What does out of proportion really mean in practice?
It means pain that's escalating rapidly. It's severe, yes, maybe 10-10, but crucially, it's not responding to your standard doses of analgesics, even IV narcotics. If you have a patient with a tibial fracture, for example, and they're just needing more and more pain meds, hitting the PCA button constantly, and it's still not touching the pain, your ACS alarm should be screaming.
That's a huge red flag.
Whoa.
Okay, so that's the main symptom. What about objective signs? What can we actually find in an exam? The guidelines seem to focus on 3 key early ones.
Yes, these 3 are critical. First, pain with passive stretch of the muscles in the affected compartment.
So for the anterior compartment of the leg, that would be passive plantar flexion of the foot.
Exactly. Stretching those ischemic muscles really fires off pain signals. It's a very sensitive sign. Second, paresthesias. Numbness, tingling, decreased sensation in the distribution of the nerves running through that compartment. That's early nerve compromise. And third, a tense or firm compartment on palpation. It might feel woody or rock hard compared to the other side. If you've got those three: disproportionate pain, pain on passive stretch, maybe some sensory changes, and a tense compartment in a high-risk patient.
You need to be calling surgery right then.
Right then. Don't wait.
This brings up a really important teaching point. The danger of relying on the old 6 Ps. Pain, pallor, paresthesias, paralysis, pulselessness, poikilothermia. Why are these unreliable for early diagnosis?
Because most of them are late findings. Paralysis, meaning motor deficits, and pulselessness, absent pulses, those indicate advanced, severe ischemia.
The damage is likely already done by them.
Precisely. Pallor, too, the limb only gets pale when perfusion has really failed. By the time you see those signs, you are well past that 6-hour window. You're dealing with probably irreversible injury. We have to train ourselves and our teams to react to the early signs, the severe pain, the pain on stretch, the subtle sensory changes, not wait for the late signs of tissue death.
Okay, so let's say we have a high-risk patient who can communicate. That young guy with the high-energy tib-fib fracture on the ortho floor or in the ICU. What's the minimum monitoring standard?
Serial physical exams. Absolutely non-negotiable. ACS is dynamic. It evolves. One normal exam on admission means nothing.
How frequent?
You need to be checking that limb, specifically assessing for those key signs: pain level, pain with passive stretch, sensation, compartment tension, every 1 to 2 hours for at least the first 24 to 48 hours.
Wow, that's intensive.
It has to be. Any subtle change, they report new tingling. The pain on stretch is suddenly worse. The compartment feels tighter. That needs to trigger an immediate reevaluation and likely a pressure measurement.
Which brings us to the really challenging situation.
Yeah.
The patient whose exam isn't reliable. The intoxicated patient. The head injury. The patient under sedation. Or the one with that regional nerve block we talked about. What's the pathway then?
Yeah, this is where it gets tough. If your clinical exam is equivocal, if you can't get reliable feedback from the patient, or if it's just unobtainable, you have to pivot. You abandon the physical exam as your primary diagnostic tool and move directly to objective measurement.
Intracompartmental pressure measurement. ICP monitoring.
Exactly. It becomes mandatory in those situations.
Let's talk about getting that objective number. ICP measurement. When is it clearly indicated? And how do we actually do it?
So the indication is basically anytime the clinical picture is murky, unreliable, or just unobtainable, like we said. Sedated patients, unconscious, maybe polytrauma patients, young children who can't communicate effectively.
Right.
Technique-wise, there are a few devices. The most common one you'll see is probably the handheld striker needle manometer system. It's pretty straightforward.
Are there others?
Yeah. Less commonly, you might see specialized things like wick or slit catheters, which can sometimes be used for continuous monitoring. And then there's the older, more manual Whiteside's technique, though that's used less now.
What's the key to getting an accurate reading, regardless of the device?
Proper placement. You need to insert the needle into the anatomical center of the compartment you're worried about. Not too superficial, not hitting bone. And you need to ensure the system is zeroed correctly, usually leveled at the height of the compartment being measured, much like setting up an arterial line or CVP.
Okay. Now, the number itself, historically, people talked about absolute pressure thresholds, like if it's over 30 mmHg or 40 or 45, that means ACS. But the thinking has shifted, hasn't it?
It really has. Relying solely on an absolute ICP number is discouraged now.
Why is that?
Because it has pretty low specificity. It can lead to a lot of unnecessary fasciotomies. Think about it. A pressure of, say, 35 mmHg might be perfectly fine for someone who's hypertensive with great perfusion pressure.
But catastrophic for someone who's hypotensive.
Exactly. If that same patient has a diastolic blood pressure of only, say, 50 mmHg, then an ICP of 35 mmHg means there's barely any pressure gradient left to perfuse the capillaries. The absolute number doesn't tell the whole story. It has to be interpreted in the context of the patient's systemic blood pressure.
Which leads us to the delta P. This seems to be the current gold standard for making the decision. Can you define that precisely?
Right. The delta P, or AGAP, is simply the difference between the patient's diastolic blood pressure, DBP, and the measured intracompartmental pressure, ICP. So the formula is AP equals DBP ICP.
And the critical threshold.
The most widely accepted threshold for recommending surgical intervention fasciotomy is a delta P of less than 30 mmHg.
So if the compartment pressure comes within 30 points of the diastolic pressure?
That indicates critically impaired perfusion, and surgery is generally warranted. It accounts for the patient's individual hemodynamic state, which makes it much more physiologically relevant and accurate than just an absolute ICP cutoff.
That makes a lot of sense. Are there any pitfalls with Measuring ICPs. Things that can give you a false reading.
Oh, sure. Technical errors are always possible. Improper zeroing, like we mentioned, making sure the transducer's at the right level. With the older Whiteside's method, you could accidentally inject a bit of saline, falsely raising the pressure. And of course, putting the needle in the wrong place, maybe in subcutaneous fat instead of deep in the muscle compartment.
And what about just doing one spot check versus continuous monitoring? Is one better?
That's still debated. Continuous monitoring, maybe with one of those slit catheters, has the theoretical advantage of showing you trends. You might catch pressure spikes that a single spot check could miss, especially if the pressure's fluctuating.
But it's more invasive.
More invasive requires more specialized equipment and expertise. So often, serial spot checks are used, but you have to be prepared to repeat them frequently if the clinical picture is evolving or the initial reading is borderline. Some studies suggest combining clinical assessment with ICP monitoring improves diagnostic accuracy significantly compared to using either one alone.
Okay. What about other things? Biomarkers, near-infrared spectroscopy, anything else on the horizon that might help, especially in those difficult-to-assess patients?
People are definitely looking into those, but right now, they don't have a primary role in the immediate diagnosis for intervention. Biomarkers like myoglobinuria or even troponin or lactate, they tell you damage has occurred.
They're lagging indicators.
Exactly. They don't give you the real-time pressure data you need to decide now whether to cut. And non-invasive tools like NIRS, near-infrared spectroscopy, which tries to measure tissue oxygenation. It's promising, conceptually.
But not ready for prime time.
Not yet. It lacks the large-scale validation and standardization needed to replace the clinical exam or delta P measurement in the current guidelines. Maybe they'll become useful adjuncts down the road, but today they aren't reliable enough on their own to base a decision for fasciotomy.
So the bottom line for diagnosis in tricky situations remains: get an accurate ICP measurement and calculate the delta P.
That's the standard of care when the clinical exam fails you.
Okay, diagnosis made. Either strong clinical suspicion or confirmed with a delta P less than 30. What happens immediately?
Call surgery, orthopedics or trauma surgery, whoever manages these at your institution. That consultation needs to be immediate and mandatory.
And critically, don't delay that call waiting for other things.
Absolutely not. Definitive treatment fasciotomy should not be held up for routine x-rays if the diagnosis is clear, or for non-essential lab work. Those won't change the immediate need for decompression. Time is tissue. Every minute counts towards that 6-hour window.
While you're waiting for the surgical team, what should the primary team be doing? Initial supportive care.
First thing, remove anything compressive. If there's a cast, cut it off, completely bivalve it, spread it. Same for tight dressings, splints, get them off.
Okay.
Second, ensure good IV access. If you suspect rhabdomyolysis might be developing because of the ischemia, start fluid resuscitation. Generous of the feed fluids to help protect the kidneys from that myoglobin load.
Makes sense. What about pain control at this stage?
It's a balancing act. You want the patient to be comfortable, so provide analgesia. But, and this is important, you have to be very careful about masking the symptoms.
So avoid regional blocks at this point if possible,
Right.
or excessive sedation.
Exactly. The guidelines generally caution against regional anesthesia or heavy sedation right before potential fasciotomy because you lose your ability to monitor their pain escalation, which is still a valuable sign, even if pressures are being checked. If a block is already in place or deemed necessary for other reasons, then continuous pressure monitoring really becomes essential.
Got it. So the definitive treatment is the fasciotomy itself.
Yeah.
Emergent surgery.
It is the absolute standard of care for confirmed or strongly suspected ACS. There's no medical management for this. The timing is everything. Immediate decompression is key. We know from studies that delays, especially beyond that 6-hour mark, are directly linked to worse functional outcomes, more complications.
Surgically, what's the main goal? Just make an incision.
The goal is complete decompression of all involved compartments. This means long, generous incisions through both the skin and, crucially, the fascia itself. It can't be a small poke hole.
And for the lower leg, which is common, how is that usually done? There are 4 compartments there.
Right. Anterior, lateral, superficial posterior, and deep posterior. Surgeons need to release all 4. There are a couple of standard approaches. A single long lateral incision can sometimes access all 4 if done correctly. More commonly, maybe, is a dual incision approach. 1 anterolateral, 1 posteromedial. The key isn't the number of skin incisions, but ensuring the fascia of every compartment is fully released. Missing one means ongoing ischemia.
That sounds challenging, and even more so in the foot, perhaps. Lots of small compartments there.
The foot is definitely complex. Anatomically, there can be up to 9 compartments, depending on how you count them: interosseous, central, lateral, medial, calcaneal.
Wow.
Yeah. And you have to decompress all of them. There's less consensus on the best incision pattern for the foot. Often it involves dorsal incisions to get the interossae, and maybe a medial incision for the deeper plantar compartments. Surgeons have to be meticulous, using their anatomical knowledge to ensure everything is opened up without damaging nerves or vessels.
Good, let's touch on a more controversial area. Prophylactic fasciotomy. Say, in a big vascular trauma case where the limb was ischemic for a while before repair, should surgeons just routinely do a fasciotomy then, even if the pressure isn't critically high yet?
That's a really interesting and evolving question, especially in high-level trauma care. The old thinking was often, when in doubt, cut it out. Just do the fasciotomy prophylactically at the time of the vascular repair to prevent ACS later.
But newer data challenges that.
Yes, some recent studies, particularly looking at extremity vascular injuries, suggest that routine prophylactic fasciotomy might not always improve outcomes, compared to a strategy of very careful postoperative monitoring, maybe serial exams, maybe continuous pressure monitoring, and then performing a therapeutic fasciotomy only if ACS actually develops or pressures rise significantly.
So more selective approach. What's the downside of doing the fasciotomy automatically?
Well, if a fasciotomy is a big operation with its own risks. You're creating large open wounds. There's a significant risk of infection, problems with wound healing, maybe needing skin grafts later, chronic pain at the site. So if you can safely avoid it through vigilant monitoring in select patients.
You spare them those potential complications.
Exactly. It's about balancing the devastating risk of missed ACS against the morbidity of the fasciotomy itself. The trend seems to be moving towards more tailored, monitored approaches rather than automatic prophylactic release in all high-risk vascular cases, but it requires intense monitoring capability.
That makes sense. One last point on intervention. Are there ever times when a fasciotomy is actually not indicated, even if ACS is present?
Yes, though it's a grim situation. If the diagnosis is severely delayed and there's already established irreversible neuromuscular damage, say the limb has been clearly ischemic for many hours, maybe 12 hours or more, and you have signs like fixed modeling, muscle rigidity suggesting rigor mortis, frank skin necrosis.
Opening it up at that point won't save function.
Right. At that late stage, a fasciotomy is unlikely to restore meaningful function and primarily increases the risk of systemic complications, releasing all those necrotic byproducts, massive infection risk, significant bleeding without offering benefit to the limb. The focus unfortunately shifts from salvage to, often, planning for an amputation once the patient is stabilized. It's a contraindication born of futility, essentially.
A terrible outcome, reinforcing the need for early action. Okay, surgery's done, the compartments are released. Now comes the post-op phase. Managing these large open wounds must be a challenge.
It definitely is. These wounds are almost always left open initially because the muscle bellies are swollen, and closing under tension would just recreate the problem. It requires a team approach.
Who's involved?
Typically orthopedics who did the surgery, often in collaboration with plastic surgery and specialized wound care services. There are several strategies to eventually get these wounds closed.
What are the options?
Once the swelling starts to subside, you might be able to do a delayed primary closure, just bringing the skin edges together a few days later. Or you can use techniques for gradual approximation, like the shoelace technique, using vessel loops or sutures to slowly pull the edges closer over time.
I've seen that.
For larger defects where the edges just won't meet, skin grafting is often necessary. And another common adjunct is negative pressure wound therapy, or NPT, the wound VAC.
How does MKT help here? Is it better?
There's no definitive consensus that it's universally superior, but NPT can be really helpful. It manages the exudate from these large wounds, can help decrease edema, promote granulation tissue formation, and might help contract the wound edges. Some studies suggest it could reduce the time to final closure and maybe decrease the need for skin grafting in some cases.
So it's a tool in the toolbox, depends on the specific wound and patient.
Exactly. The optimal strategy is often individualized.
With these big open wounds, often in tissue that was already traumatized or ischemic, infection has to be a major worry.
Huge worry. Infection rates after fasciotomy are significant. Some series report rates up to maybe 16 or 17%.
That's high. Any particular bugs we worry about?
Pseudomonas aeruginosa is a notorious player in these wounds, often resistant. But you can get polymicrobial infections too. Vigilance is key, looking for signs of infection. Empiric amniotic coverage needs to be broad initially, guided by local resistance patterns. Often combinations like aminoglycosides plus beta-lactams are used, maybe adding quinolones if it's a high-risk trauma or burn patient.
Okay. Assuming we get through decompression, wound closure, avoid major infection. The patient isn't done yet? Rehabilitation seems critical.
Absolutely critical. Early mobilization and intensive physical therapy are essential. These patients are at very high risk for developing contractures.
Like foot drop.
Foot drop, if the peroneal nerve in the lateral compartment was badly damaged or the ankle gets stuck. Claw hand deformities after forearm ACS. Stiffness, loss of range of motion. PT is vital to try and maximize whatever functional recovery is possible and prevent those long-term limitations.
Let's circle back and really hammer home the consequences of getting this wrong. The sequelae of missed or delayed diagnosis. Why is that 6-hour window so sacred?
Because the outcomes of delay are just devastating and often permanent. You get irreversible nerve damage, leading to chronic sensory loss, numbness, neuropathic pain. You get irreversible muscle damage, leading to permanent weakness or paralysis, like the foot drop or claw hand we mentioned.
Functionally crippling.
Totally. Then there are the contractures that limit joint movement. Chronic pain syndromes are also very common after significant ischemic injury. And of course, the ultimate consequence is limb loss. The risk of needing an amputation goes up significantly with each hour of delay past that critical window.
And the systemic issues we touched on earlier.
Right. If the muscle necrosis is extensive, you're managing the fallout from rhabdomyolysis, especially the risk of acute kidney injury. Widespread infection can lead to sepsis. It's not just about the limb, it's about the patient's overall survival and systemic health. The functional morbidity, the long-term disability, the economic costs, the medical legal implications. They're all immense when ACS is missed. Early recognition isn't just good medicine, it's crucial risk management.
Okay, let's try to synthesize this. Acute compartment syndrome.
Yes.
High stakes, incredibly time sensitive, requires immediate, decisive action.
Absolutely. The number one takeaway for everyone listening has to be maintain a very high index of suspicion in high-risk patients. Don't ignore escalating pain.
And rely on the earliest reliable clinical signs. That pain out of proportion.
Pain with passive stretch.
And paresthesias or sensory changes. And palpating for that tense compartment. Don't wait for paralysis or absent pulses.
Always don't wait for those. That's too late.
And if the clinical exam is unreliable, the sedated patient, the intoxicated one, the patient with a nerve block,
you must move to objective pressure monitoring. Measure the ICP, calculate the delta P.
And that threshold of delta P, less than 30 mmHg, between diastolic pressure and compartment pressure, is the trigger for calling surgery immediately for decompression.
That's the current evidence-based standard. Complete emergent surgical decompression. Delays are catastrophic. There's just no way around it.
Aggressive monitoring, whether clinical or with pressures, and rapid surgical response. That's the formula right now.
It is. It's about integrating that clinical suspicion with objective data when needed and acting fast. Maybe reserving purely prophylactic fasciotomy for very specific, highly monitored situations based on that newer evidence.
So looking ahead.
Yeah.
We still rely heavily on that invasive pressure measurement. When the exam isn't enough, it works, but it's invasive. Where do we go from here? Is there hope for better, maybe non-invasive diagnostics?
That's the big question, isn't it? Especially with potentially more patients falling into that unreliable exam category, maybe more regional anesthesia, more complex polytrauma patients. Can something like continuous tissue oxygenation monitoring with NIRS or some other technology eventually become reliable enough? Could it safely replace or augment the delta P in clinical exam?
It would be a game changer if it could.
It really would, but it requires a lot more research, rigorous validation, standardization of protocols, proving it's safe and doesn't lead to missed cases. That's really the next frontier, finding ways to improve diagnosis and guide therapy, especially for those non-communicative patients, to hopefully improve those long-term functional outcomes even further, perhaps with less reliance on invasive measurements or maybe even avoiding some fasciotomies safely.
A critical area for future research indeed. Improving outcomes for this devastating condition has to remain a priority.